Hi everyone, my name is Ari. I am a registered dental hygienist, and I'm going to be sharing with you a case today that came into the office. So we have male patient MC, age 58, his height is 5'9", and his BMI was 22.9, so a pretty healthy weight. His chief complaint was, I wanted to explore my options with homeopathic medicine since conventional medicine made me worse. His health history comprises of cancer of the throat, which was treated with chemo and radiation back in 2017. That was deemed cured. And then a new diagnosis of stage 4 tongue cancer arose in 2019, right after extractions of teeth numbers 19 and 31. His dental history has amalgam restorations, as you can see, several teeth here, PFM crown on 14, porcelain crown on 30, and a few missing teeth as well. This is his dental chart as he presented. During the clinical evaluation, there's no carious lesions presented, and the marginal integrity of the restoration seemed to be intact. The biggest notable fact was his severe xenostomia, which is kind of what we would expect someone that went through some chemo and radiotherapy. It's constant phlegmy expectorant. He was very uncomfortable and had to be seated upright for the most part, and constantly had this thick sputum that he had to constantly spit. Some hyperplastic salivary glands exhibited in the soft palate, and then the biggest of all was the largest swelling on the posterior right lateral border of the tongue, and that had a white and reddish look to it with ulcerated presentation, and that was also very painful when touched. This is his perio chart. One thing I want to make a quick note of was that his hygiene was pretty good. He definitely tried at home to maintain things and keep the plaque levels low, keep the acidity in his mouth very low. Even though he did only use a manual toothbrush, he used natural toothpaste, baking soda, with saltwater rinse, and used a water pick. I thought the baking soda rinse was great as far as trying to buffer down any acidity in his mouth to keep him from having cavities. And I think that really helped him since there were no carious lesions in the mouth. And I did tell him that the salt in the water wasn't really necessary since he was using the baking soda, but it definitely was good for the gums to keep some inflammation down. But overall, he presented with little plaque, little calculus, barely any actually, and then bleeding or probing was localized to the buccal of 14 and 15. There was one area of deep pocketing, residual pocketing rather, 5 millimeters, no bleeding and probing. That was between 3 and 4 on the palatal side. But the concerning part was the clinical attachment loss. Now, he had a generalized moderate amount, 1 to 2 millimeters of recession throughout, and then areas of any pocketing brought it to like a 5 to 7 millimeter CAL. We didn't have any new radiographs to compare, so due to his health history, we decided to not take any today. He presented with this full mouth series from 2016. You can see a little bit of bone loss in some areas. The lower interiors here, you can see around like 30%. But based on what we had, pretty much gave him a diagnosis of stage 3 grade B as far as perio goes. Was not accurate, obviously, but something to be aware of when moving forward with the patient. So, his background story is the most interesting. So, he explained to me that after his chemo radiotherapy for his throat, he was having pains in the lower right mandible around tooth number 31. And he went to the hospital to have it checked. They did some testing, maybe some, I don't know if they had any radiographs. They didn't really clarify whether or not they took any other diagnostic images or not. But he was referred to a general dentist, which took that FMS and CBCT. So what he said was that the dentist did not think there was any pathology on any of the teeth. he did not know what to do. So the best option I guess he gave him was to extract a tooth that gave him pain, which is 31. And he did mention that number 19 had a slight possibility of a periapical pathology, but again, did not believe that it needed to be treated with a root canal. I guess, I don't know, these are just the story that he posed. So at the end of the day, the dentist took out number 19 and 31 in hopes to get rid of his pain and get rid of any possible infection. So later that year, he stated that he went for his checkup and all of a sudden he had this massive lesion on the right side of his tongue, very similar to the photo that I added here. Like I noted, this is not the actual photo, but it's pretty much spot on how it looked when I was taking a look inside. So as a hygienist, we are trained to deal with these kind of patients. The typical would be just, brush and floss, give some fluoride to help prevent any cavities. Obviously stay away from alcohol, mouthwashes, and just keep them on a 3-month recall maybe just to help with any possible inflammation, or keep an eye on things. But in the world of biologic dentistry, I think it's important to be able to recommend much more important adjuncts to any therapy that's given. And IV drips now are becoming more and more popular, and I really believe that recommending something like this, like IV drips with vitamin C and glutathione, specifically in this patient that has a lower immune system due to his chemotherapy, obviously with cancerous history, he has a lot of oxidative stress going on in his body. So the glutathione is perfect for trying to relieve some of that. Vitamin K2 is also very important. That obviously helps with multiple things as far as blood goes and bone deposition. But in this case, because it's possible that he had some kind of radionecrosis of the jaw, bone anabolism with K2 cofactor would be very important. Some of the other things just to kind of have floating in the back of your head as a hygienist is like, okay, we might not take a full mouth series, but the root cause of this problem is somewhere within the bone, most probably, for its chief complaint as far as that goes, of pain in the mandible. So maybe a CBCT after some consulting with his primary care, maybe, and that's to evaluate any cavitations that were left behind from the extractions of 19 and 31, even 32, which is this previous extraction of his wisdom tooth. Amalgam removal would be somewhere in the thought process as well. He does have a lot of mercury fillings in his mouth, so again, just to overall better the patient's sensitivity to any materials that could be harmful, removing the amalgam might be a good idea. And then saliva max calcium phosphate rinse. This is one of my favorite things to recommend to patients with xerostomia. It's a very easy system to be able to have them get sent to their home and use a little packet every day as much as they want. That's to promote salivary flow. And again, same thing as with the bicarbonate rinse that he was making, just kind of buffer the acidic environment. Then electric toothbrush would be probably better to be using rather than manual, since he does have a history of recession, probably brushing very hard, and you don't want to make that clinical attachment loss any worse. So the electric toothbrush would be a benefit for him to be using. So as I was just saying, the typical thought process and how we're trained as a hygienist, the first couple of lines here, but I want to go past that a little bit and just state out, how did this patient get to this state? Given the background story, the first thing that came to mind was of neuralgia-induced cavitational osteonecrosis. Now, obviously, this is not a diagnosis. This is more of a possibility and cause of his idiopathic pain in the lower right side when he first went to the hospital. And at that time, he only had number 32 missing in that area. So again, it's possible maybe there was a cavitation in the lower right jaw area there, and that could have been worsened due to the radiotherapy that he received for his throat cancer. So again, now we have the possibility of this osteoradionecrosis in this area, this void in the bone. Um, Obviously, chemotherapy was done as well. Had a suppressed immune system for a long time, and then that again could have potentiated any possible either bacterial pathogenesis in that area. And even though we don't know at this moment, or that first visit where he came in, where or if there was a potential cavitation in the area, it was near the area of the oral cancer, the tongue cancer. So it's just adjacent to the sublingual space, right under the huge swelling. And again, as I mentioned earlier, the oxidative stress and the lack of blood supply in the area, it could be related to the reason why he had this aggressive tumor growth in the tongue there. So again, just as I mentioned, at this time, and again, as a hygienist, you can't do much except for recommend certain therapies or try to lead the patient in the right direction, along with having the dentist come in and make an overall definitive diagnosis and create a treatment plan or create a path that will help him improve his health and maybe even the cancer. So yeah, IV drip therapy, vitamins, minerals, grasp on the systemic homeostasis. It's the best thing we could do right now for this patient. And then hopefully at his next visit, we'll have a much more clear answer on what is next. Thank you.